Association, Dr. Shantanu, Lahkar. Well, this is a master training program in which we are talking about ankylosing diseases of spine and spondyloarthropathy. Well, President Ramesh Sen is abroad and he has sent a inaugural address message. I'm trying to play it. Hopefully it should play.
Hello everybody. Like usual, our rheumatology subsection of Indian Orthopaedic Association has been doing a wonderful job, and I'm really happy that this time also they are organizing the next session of this program, which has been continuing so regularly to a lot of knowledge about orthopedic as such. All my best wishes, and definitely thanks to Dr. Chaddha and Dr. Bhushan to have continued. All best wishes. Thank you.
Thank you, Dr. Ramesh Sen, for always giving your best wishes for orthopedic rheumatology, which is really not the routine kind of orthopedics. It is definitely different. Now, can I request our President-elect, Dr. Atul Srivastava, to just a minute, having little glitches, right. And so, Atul, please.
Good evening all. Welcome to this IOA Orthopaedic Rheumatology Masterclass webinar. This is a fantastic webinar today, and the topic today we'll be discussing on ankylosing diseases and spondyloloarthropathies, on which we have already worked last year under the guidance of Dr. Jha and the banner of IOA. Friends, let me tell you one thing, that the panel that you have today, their zeal and enthusiasm, their dedication, commitment, and sincerity is parallel to none. And it's exemplary the way they dedicate their time for the sake of the general members of the IOA. It's exemplary and worth emulating, I would say. I congratulated them all, and I'm sure that the deliberations will enhance your knowledge a lot more. So let's go on with the deliberations, and thank you so much for inviting me.
I personally feel very happy that you came down while you were traveling and you are here. It's a great moral booster. Now, our secretary Navin Thakkar has joined. Okay, whenever he joins, he will have his own remarks. So, Dr. Shantanu, Lahkar, President IORA, your opening remarks, please.
Good evening to all. Respected, most respected Dr. S Jha, who is the past President IORA, also guiding force of IORA. Most respected faculty of the station, respected our President-elect IOA Dr. Atul Srivastava for the very kind word for IORA, and all the faculty present over here. I, on behalf of IORA, like to extend my heartfelt thanks to all of you for giving your time, valuable time, for this master course in rheumatology side, and I hope this will give lots of information, update information to us. Thank you very much. Thank you.
Thank you. And now it is the turn of nobody else than the convener of Rheumatology 2022, Dr. Pannag Bhushan.
Namaskar, sir. Am I visible and audible?
Yes.
Thank you very much for all the participants who have come here, especially our senior officials like Dr. Atul Srivastava, who had been an incessant and continuous inspiration to this association and to this Indo-Indian Orthopaedic Rheumatology. We have gone leaps and bounds beyond that, and now almost all theoretical things are over, as suggested by these two presidents, the Srivastava ji and Sen Sahab. We'll be discussing about the surgical part later on also. Today, we'll be discussing the most difficult and less understood part of the orthopedic spondyloarthropathy, seronegative. Welcome again, all of you. Thank you very much.
Thank you. And I take the opportunity to welcome Dr. Swarnendu Samanta, and Alok has still not joined. Maybe he joins later. Friends, we start with the introductory presentation, and the topic is, let us not forget other ankylosing spinal diseases. Friends, whenever we talk about ankylosing spinal diseases, it comes to our mind that it is the one finality of this disease process known as ankylosing spondylitis, and now more popularly known as spondyloarthropathy. But we forget that there are other conditions also which also lead to ankylosing spinal diseases. So they are underappreciated. There is delay in diagnosis, and they have ossification of one or more ligaments in the spine. There are 4 major causes. One definitely is ankylosing spondylitis, or to start with, we can say non-radiological and radiological spondyloarthropathy. The latest name for ankylosing has become radiological axial spondyloarthropathy. The other condition is DIS, and DIS is dissociated idiopathic skeletal hyperostosis. Mind you, all others are inflammatory. This one is non-inflammatory. The third one is EASM, and EASM is end-stage advanced sclerosis multiforme. This is an inflammatory condition, can have either metabolic or endocrinal disease, advanced age degenerative arthritis. It is presented, and these may be some of the patients where we say EORA, elderly onset rheumatoid arthritis. The other one is idiopathic hypertrophic osteoarthritic patterns and fluorosis. Each one of us have seen in plenty. The next one is OPLL, that is ossification of posterior longitudinal ligament, affects persons of mainly Asian descent. 2.4% is the incidence, and twice common in elderly men, predominate in 5th to 6th decade of life. Friends, we have to remember as differential diagnosis between ankylosing spondylitis and DIS. The most important point is that while hyperostosis is present in both of them, sacroiliac joint erosions are not present in DIS, whereas it is present in ankylosing spondylitis. Anterior longitudinal ligament ossification and posterior longitudinal ligament ossification are present in DIS, whereas it may not be there, it should not be there in ankylosing one. Syndesmophytes and erosive enthesitis are the hallmark of ankylosing spondylitis, but not seen in DIS. With these introductory remarks, I would like to request Dr. Ravi Gupta from Chandigarh to tell us about spondyloarthropathy, the current concepts. Now I stop sharing.
So good evening to all of you. So is my screen visible to everyone?
Yes.
Okay.
Not full screen yet.
Not full screen yet. Now it's okay?
Yeah.
All right. So I'll be talking about the current concepts of spondyloarthropathy. And I thank everyone, especially Professor Jha, who helped me out to give me this slot of the first talk. So in this lecture, we'll be covering the terminologies, classifications, current load of the problem, diagnostic criteria, algorithms of treatment, and current occupational and social impact in a brief manner. We have different lectures on almost all these topics later on, which will delve on in a detailed manner. So what is spondyloarthropathy? It's a group of overlapping disorders of chronic inflammatory disease of autoimmune nature, sharing certain clinical features and common genetic association with HLA-B27. So this is the present definition which is accepted for this disease. So earlier times, we used to talk about the seropositive rheumatoid arthritis and seronegative. And these spondyloarthropathies, they were considered as seronegative, which included ankylosing spondylitis or axial spondyloarthropathies and the peripheral spondyloarthropathies. So spondyloarthritis is actually a seronegative spondyloarthropathy. When we say seronegative, that means the rheumatoid factor is negative. Actually, it can present either as an axial manifestation, that means of the spine or the sacral-like joints, or in the peripheral areas, which may be joints, which may be the ligaments or the tendons as they attach to the bone. So actually, there are so many groups: non-radiological axial spondyloarthropathy or radiological. So these are the axial ones, and the peripheral ones can be related to musculoskeletal system, or in the initial stages, they may be like inflammatory bowel disease, which may involve later on the peripheral as well as the axial joints. So typical extra-articular manifestation, it is with acute anterior uveitis, with psoriasis, with inflammatory bowel disease, which can be either Crohn's or ulcerative colitis. And these extra-articular manifestations are in the form of enthesitis, most commonly in the heel, plantar fasciitis, or dactylitis in the hands. So it's a common problem in India. It is second to rheumatoid arthritis. Prevalence of this disease is linked to the prevalence of HLA-B27. And we know that HLA-B27 is on an average 6% in Indian population. So that is why this is also common. If you look at the low backache patients in our clinics, of all the low backache patients, around 1 to 2%, they are suffering from spondyloarthropathy. The male is to female ratio, in earlier times, we used to think that the males suffer much more commonly than the females. But recent studies, they show that the difference between males to females is 3:1. In fact, for the non-radiological spondyloarthropathy, it is almost same. This is mostly due to more awareness of the diagnosis and early diagnosis. So higher peripheral arthritis is again, it's reported amongst Indian axial spondyloarthritis patients. If you compare with the rest of the world, we suffer more from peripheral arthritis in addition to the axial spondyloarthropathy. It has been seen that most of the times there is a delay in the diagnosis to the tune of 5 to 11 years. And the reasons are the radiographic changes, they develop late, presenting symptoms are vague, and criteria used to diagnose this ankylosing spondylitis may lack sensitivity, so that we want to diagnose ankylosing spondylitis, the typical features they come with. Many physicians have inadequate knowledge about ankylosing spondylitis as well as spondyloarthropathy, and they underestimate the prevalence. I think that's the reason this group is trying to create awareness amongst the general orthopedic surgeons. It has been seen in this study from India, recent study 2020, that the delay in diagnosis is significant. Of all these patients, only 31 patients were actually diagnosed. The rest of the patients, they were not properly diagnosed. And the correct diagnosis was because they were non-rheumatologists or there was no awareness. The other reason for delay in diagnosis is the patients, they go to many other specialties before they actually come to a rheumatologist. So there are various specialists, they are visited, so they lead to delay in the diagnosis. Another important point which is given in this study is 58% of the patients, they don't want to come to allopathic people. They think that they have side effects, so they go to other specialties. And 25% believe that the doctors, they deliberately conceal the side effects. So that this is again contributing to the delay in diagnosis. So if we look at the early diagnosis, there are some pearls. A chronic backache, which is more than 3 months of duration in a patient younger than 45 years of age. And if he has one of these two, that is sacroiliitis on imaging, plus one or more features of spondyloarthropathy, which are given here, these features, or HLA-B27 is positive in this patient, plus there are 2 or more features of spondyloarthropathy. So I think in the subsequent lectures, it will be told in more detail, so I can skip here. Another important fact is, as I mentioned, the delay in diagnosis. So, but the disease is continuously progressing. If you diagnose early, you can treat early, the outcome is much better. It has been seen that the undifferentiated or pre-radiological stage is usually up to 5 years, when you can still pick it up on MRI. But after these 5 years, the disease starts appearing in the X-ray, and then 5 to 10 years, it is like this. And beyond 10 years, you can see the features in addition to sacroiliitis, the features in the spine also. Now we have future role of biomarkers, because you want to diagnose it early. So people are studying that there is some subclinical gut inflammation in at least 60% of these patients, which is due to alteration of the gut epithelial and vascular barrier, leading to increased permeability and absorption of these products of inflammation into the bloodstream and the system. And this actually occurs because of imbalance between the good bacteria and the bad bacteria. So there is a gut dysbiosis, and these are the various bacteria which become abundant in these patients, and then those products, they go into the bloodstream. So now we are thinking that if we can identify the specific biomarkers or a panel of molecules to profile these patients, especially in the early stage of the disease. But still, you know, it is in the research stage. If you can find out those products, you can diagnose it at an earlier stage. So if we look at the algorithm of treatment, the current algorithm is, if the predominant manifestation can be either axial or peripheral, the first line of therapy is non-steroidal anti-inflammatory drugs, and other important, this is very important, the non-pharmacological treatment. Unfortunately, our allopathic doctors, the modern medicine doctors, we focus less on patient education, exercise, physical therapy, rehabilitation, lifestyle modifications, And that's why the patients, they are losing faith. And then in the first line itself, one can use local steroids or sulfasalazine can be given. If it does not work, then we go to the second line, which is the biologicals, including the tumor necrosis factor alpha and various inhibitors of interleukin 17 and others. In addition, analgesics, and at some stage, the surgery may be required because of the deformities. Now, what is the burden of this disease? This disease is such a chronic disease. It affects the patient's day-to-day health and the quality of life. It has been seen that many patients, they have absenteeism. These are the terms which are used in the literature. That means the patients are not able to go to work. Presenteeism means the patient is going to work, but his productivity is reduced by less than 50% due to the disease. So although he is present, but his outcome of his work is less than 50%. So he requires more days with the help of someone else, and he misses the social activities also. So this is the impact of the disease. This is one of the studies which has shown that, these are the number of days which are missed by so many people, 0 to 30 days by 56 people, 31 to 60 days by 35 people in a year. So this is the impact of the disease. If we look at the Indian scenario, this study again by Reddy et al., 8% of our patients had to cease employment due to debilitating consequences of this disease.
Dr. Ravi, you can conclude now.
Yeah, daily activities were affected up to 40% and median presenteeism is 20%. So in summary, we must use correct terminology in line with the international terminology. We must be able to create awareness amongst our colleagues so that we make an early diagnosis, and we should follow the criteria for early diagnosis and treatment. And we must know that this disease has a lot of impact on the social status as well as productivity of the patients. Thank you very much. Sir, with your permission, can I leave?
Sir, you are muted, sir. Ja, sir. Please unmute yourself.
Okay.
Right.
Thank
you. So thank you very much. Just one point I wanted to make, that you have highlighted a very good work that autoimmune subclinical inflammation of late has become so important. And it is postulated that the initial pathomechanics is located in the gut itself of all the rheumatic diseases. So thank you very much. Yes, you can leave now. Now, I will request Dr. Dhansekhara Raja from Coimbatore, and he will clarify on pathogenesis of spondyloarthropathy and ankylosing spondylitis.
Thank you, Professor Jha. And thank you, the IOA committee, for the opportunity. So I'm going to talk about spondyloarthritis and ankylosing spondylitis, pathogenesis. So why we talk about pathogenesis? Because we have limited knowledge of the pathogenesis of the spondyloarthritis, and there is always confusion in diagnosis. A lot of patients come for back pain, and they continue to get treated with NSAIDs and physiotherapy, and final diagnosis is not established till they progress to late diseases. We don't know what is the current investigation to get the correct diagnosis, what are the available treatments, and a lot of newer therapeutic agents like tumor necrosis factor alpha inhibitors and IL-17 inhibitors have come. So we need to know the pathogenesis to understand the treatment modalities and diagnosis. Spondyloarthritis is a family of inflammatory rheumatic diseases which have few common features. They have inflammatory type of back pain and stiffness of the spine and pelvic joints. They have enthesitis, inflammation at the attachment of the ligaments and tendon. And the common connection between these spondyloarthritis is the presence of HLA-B27. So there are typical extra-articular manifestations which we need to look into so that we can do a proper diagnosis. Many of the patients with spondyloarthritis also have anterior uveitis. 30 to 40% of the patients have that. They can have skin lesions like markers of psoriasis. They also can have inflammatory bowel diseases like Crohn's disease and ulcerative colitis. So if you have any patient with the inflammatory back pain, you should look into other extra spinal manifestations. So we saw this slide before, progression of spondyloarthritis over time. So usually it starts in the pre-radiological stage, then progresses to a radiological stage. So the pre-radiological stage presents with inflammatory back pain, peripheral arthritis, and enthesitis, and X-rays are normal. So they can have active spondylar sacroiliitis in the MRI. So we should always suspect this and order an MRI if you want to do an early diagnosis. So once they progress, they have a radiological diagnosis where there is sacroiliitis visible on the X-ray. They also have the same features of inflammatory back pain, peripheral arthritis, and enthesitis. This progresses over the next 5 to 10 years. And then this further goes for frank syndesmoid formation and fusion of the spine. This is evolving over 10 years. But if you suspect and have an MRI within first 5 years, we can diagnose the condition with the MRI. If you look at the MRI, if you see there is active inflammation in the back, both in the spinal joints and the sacroiliac joint. This is a typical MRI, specific MRI, PET MRI, which shows high activity in the spine and sacroiliac joint in a patient with pre-radiographic ankylosing spondylitis. So MRI is the now go-to diagnosis if you are suspecting inflammatory arthritis and ankylosing spondylitis. So the ankylosing spondylitis is one of the spectrum of spondyloarthritis, where there is radiological sacroiliitis, which evolves over the time into a complete fusion of the spine. They also have extra-articular symptoms like enthesitis and uveitis, and these are the predictors of ankylosing spondylitis. The pathogenesis of ankylosing spondylitis includes 4 different theories. There is no specific theory, but these are the 4 established theories. One is genetic risk factor. Second is immune reaction. Third is microbiological infection. Fourth is endocrine abnormalities. So first we look at the genetic background. This is a more relevant and more well-studied pathogenesis. All patients have familial aggregation. They have a common gene called MHC gene called HLA-B27. Other MHC genes also has been seen to predispose to ankylosing spondylitis, and now they have founded non-major histocompatibility complex genes also. So we look at the familial aggregation. The susceptibility between relatives is very high. So if you have identical twins, the concordance rate is almost 63%. If they are non-identical twins, it is almost 23%. So there is high incidence even first-degree relatives. So you look at the HLA-B27 gene, which is one of the most important genetic marker for ankylosing spondylitis. We are suspecting ankylosing spondylitis, inflammatory back pain with sacroiliitis. We need to order for a HLA-B27 test. So it is highly prevalent. 1 in 3 patients with HLA-B27 marker progress to ankylosing spondylitis. And if you have first-degree relative, there is increased chance of getting HLA-B27 positivity. It is autosomal co-dominant inheritance, and 20% of the patients will have a reactive arthropathy if they have infection of chlamydia or salmonella. So this HLA-B27 predisposes to reactive arthropathy, and males have more preponderance compared to females. And the common age group is around 21 to 40 years. So we also see that because of this predisposition, many patients develop reactive arthritis and also bacteria-induced inflammatory arthropathy of the gut. Other immunological factors which have been indicated as a causative for ankylosing spondylitis includes a change in the bacterial flora of the gut, and Klebsiella pneumonia has been specifically attributed as an exacerbating factor. And it also, these bacteria has been influencing the immune mechanism, and immunosuppression and immunodeficiency also can predispose to inflammatory arthritis. So coming to MHC gene, major histocompatibility gene, HLA-B27, More than 136 subtypes has been identified. And these are the specific types which are commonly seen in ankylosing spondylitis patients. Again, the causative problem is change in the HLA-B27 heavy chain. So these genetic problems causes change in the HLA-B27 heavy chain, which in turn causes a reaction in the cells, which releases inflammatory mediators. So we have the antigen presenting cells, macrophages, B cells, and dendritic cells, which when they are exposed to these arthritic peptides, the HLA-B27 unfolding happens. This causes endoplasmic reticular stress. This endoplasmic reticular stress causes release of interleukin 17, interleukin 23, and type 17 immune response. These two causes release of inflammatory mediators, causing release of interleukin 23. So we see that HLA-B27 causes intestinal dysbiosis, resulting in overexpression of the interleukin 17A pathway and interleukin 23 release. This interleukin 17 pathway causes release of interleukin 17 and interleukin 23, which acts on the end organs of the osteoclasts and osteoblasts, the fibroblasts, and the macrophages. When these work on these end organs, this causes release of tumor necrosis factor alpha. This tumor necrosis factor alpha is the key mediator which causes syndesmosis formation, bone erosion, and colitis. So now we have drugs which can inhibit the tumor necrosis factor alpha, like example is infliximab, which can change the course of the disease. Other factors, other drugs like secukinumab, they can also influence the interleukin 17 pathway, and they can give decrease in symptoms and remissions. So you look at other spondyloarthritis like psoriatic arthritis, they also have inflammatory back pain, other skin changes and nail changes, and this progresses over a period of time. So if you understand the pathology, you can do an early diagnosis. So if you see a patient with back pain with skin lesion and psoriasis, you know they are progressing to spondylar arthritis. So now we can intervene early and make sure we can diagnose and do the intervention early. So understanding pathogenesis of spondyloarthritis helps in the diagnosis, helps us to do a relevant investigation. We can start the disease-modifying therapeutics at the early stage so that patient get good remission, and we can modify the therapy before surgery. That is also important. Understanding how these biologics work is very important to modulate them before the surgery when you're planning for a joint replacement at a later stage. Thank you very much.
Thank you, Dr. Raja, for a very lucid presentation of pathogenesis and how various interleukins come into play, especially IL-17, IL-23, and TNF-alpha. Now is the turn of next speaker, Dr. S Amarnath from Bengaluru, who speaks on non-radiological investigations. Dr. Amarnath, please.
Thank you, sir. Thank you for the opportunity. And I hope you people are able to see the screen.
Full screen. Yeah, now go to full screen. Right, you're there.
Thank you. Thank you. I'm going to be very quick and swift because now there will be a lot of overlap on this subject. There will be a lot of terminology that we all speakers, colleagues of ours are going to be talking about. The idea behind that is repeatedly, when once it is hit, we need to get it absorbed, and definitely it takes the mark of early diagnosis. So I thank all the organizations, and this is where I represent the institutions and the organizations. Thank you. And today, to tell you frankly, we are obviously knowing this post-COVID world. Now, going back in time, whether it's going to be dengue or chikungunya and a lot of other things, what did cause the challenges that we went through. So we have to keep all those things in mind as well, because post-viral issues are going to be a major thing that we all have to keep in mind, apart from just thinking on only spondyloarthropathy or, is it going to be ankylosing? So this is a very important point. And with that early diagnosis, And I'm sure all of us agree that we need to make sure that we are going to give and make this a better place for each and everyone to live in. So with that little intro, obviously all of us know that we are going to be talking on this, and I'll be focusing mainly on the non-radiological investigations that can be covered in terms of identifying ankylosing spondylitis and spondyloarthropathy. So that is the most important key factor that we need to talk about and share the details of the problem that we have in hand. So keeping that in mind, obviously this has been taken care in the past. Now we have to be very, very clear in each and every steps. So we'll talk about the blood and bone markers to start with, because it could be non-surgical, it could be surgical, but definitely the key factors is each and every doctor, be it a seasoned orthopedic surgeon or even a training orthopedic surgeon, that we need to look at as the essential factors. So keeping that in mind, yes, the most commonest thing as we do for a pre-operative check, these are the things that we need to keep in mind. We need to differentiate the hormonal. Is there inflammatory markers? Is there going to be any kind of an autoimmune issue that is already there? And many of them have a deficiency in their nutrition, which is extremely important factor. Many of us tend to forget that. So these are very important for us to understand. Iron profile is very important. Now, many of them are deficient in iron. Hemoglobin may be normal, but they have a ferritin, and the saturation of iron is so low. And obviously, we need to differentiate, is it going to be a RHD positive, that is rheumatoid factor positive or a negative? So it's going to be a seronegative arthropathy. So all these things have to be very, very clear for us. Many a times we may need to include anti-CCP. Anti-cyclic citrinated peptide is extremely important for us. Many a times rheumatoid factor can be negative, but anti-CCP may be positive. So hence, I insist upon keeping that as an involvement. Do we do it routinely for every back pain within a month or two? No. When there is going to chronicity, 3 to 6 months, and obviously that's very, very important for us to differentiate and take it forward. Now, vitamin D, vitamin B complex, we don't need to do all the vitamin B complex tests, but B12 is very sensitive, that's good enough, and gives us a picture where they stand. And hormonal obviously is very, very important for us. And steroid, at times we may need to, but we can take it as a case and we talk about it. Obviously, apart from the kidney functions, in the kidney functions, we talk about uric acid and a lot of other things coming into picture. There, we have to include the electrolytes, and serum electrophoresis, the protein electrophoresis, is very, very important for us. Apart from just being an M-band, is there any other thing that is coexisting? And there could be a sickle cell and a lot of other things we talk about. And antinuclear antibody. Now, one point I would like to talk about antinuclear antibody is you need to understand and guide the patients, because we don't need to do the profile every time. Generalized ANA, anti-nucleic acid test, if that is positive, then we go to the ANA profile and take it, because that's costs are going to be very high for them. So naturally, that's an extremely important point. Just keep in mind, and this is very important. Apart from that, we also have in the research, what was mentioned earlier, we have Calgreen myeloid, MRP8. This protein has been shown to be higher in both ankylosing spondylitis, spondyloarthropathies, but not in osteoarthritis. So this is an extremely important point. This is not routinely done, but definitely it's available in very high centers and more of a research. Yes, I agree with. And apart from that, we have CARD15, gene polymorphisms which are happening, which Dana talked about, a lot of other changes which are happening in interleukins. Even there, these can be variant, because we need to observe depending on what kind of target therapy what we're going to give. That's very important for us. So that's the reason it's a key factor for us to understand and establish the pre-treatment stage where each one of them are. And obviously, there are different allele coming into the tumor necrosing factor, which could be 308 and 238. Now, why we need this? There is a differential in the response. Now, why? Not every person who is taking anti-TNF is going to be responding. Is he a responder? He or she is responder or non-responder? We need to look into those things as well. So it's extremely important, the variance in the gene, so that we can try to give them the regular biologicals or probably the targeted ones. So it's extremely important for us to take it forward. So I don't want to confuse you more, but definitely, apart from all these investigations, we should not get forgotten. Obviously, it's been told again. I'm just going to highlight that we need to get and work as a team. So there is a team of gastroenterology, ophthalmic, dermatologic. We do the check on the skin anyway. So just to make sure that, and orthopedic examination from us is extremely important. Make sure that with the minimum clothing, every patient is examined so that we can advise them very early, pick up early, treat early, so that we don't have to get into the surgical aspect at this juncture. I take this opportunity to thank all the organizations that is involved, and thank you. Thank you. I'm going to stop sharing now.
Thank you, Dr. Amarnath, for giving a very good presentation and delving into the aspects where the answer is still not there. Like you have very rightly said, that this particular patient is a responder to the TNF-alpha or not. And there your 308 and 238G allele testing will prove to be a good tool. Thank you. Thank you very much.
And also teamwork.
Right. Welcome, Dr. Dilip. Now, before I hand over, you all of us have seen that big boss. So there is a wild card entry today. Can anybody think who is going to be there as a wild card entrant? Dr. Mohit Arora from Gurugram. He speaks on juvenile idiopathic arthritis, latest updates. Mohit, are you there? Mohit?
Yes, sir. Yes, sir.
Yes.
Good evening, all, sir. Yes.
Go ahead.
Yeah. So, okay. So I'll start with the presentation. Just.
Amarnath has left.
Okay. We always keep on talking about adult spondyloarthropathy and very briefly discussed about the pediatric one. There is a lot of variation in nomenclature also. So Dr. Mohit has been assigned the task to discuss this juvenile one.
Right. Good evening, all, and thank you, Professor Jha sir, for providing an opportunity to speak on this topic. So, juvenile idiopathic arthritis, it basically comprises of all the arthritic disorders, be it a seropositive spondyloarthropathy or a negative spondyloarthropathy. So, it just comprises all of them. So, the aim of this presentation would be to understand the classification of juvenile spondyloarthropathy and to understand the treatment in juvenile spondyloarthropathy. Now, by definition, it is defined as a presence of arthritis of unknown etiology that begins before the age of 16 years and persists for at least 6 weeks. The International League of Association for Rheumatology, ILAR, has classified into various subtypes of autoimmune inflammatory disorder. It is based on number of joints affected, the presence of systemic symptoms, and detection of rheumatoid factor. Now, the classification is like that. The first one is oligoarticular juvenile idiopathic arthritis, meaning the less than 4 joints are involved. They are asymmetric. Large joints like knee joints are involved mainly. There is a female predominance. As Dr. Amarnath said, there is a extra articular manifestation like 30% of uveitis, and majority of them are ANA positive. So in GIA, the main test is antinuclear antibody test rather than rheumatoid factor test. Now, the second group is polyarticular GIA with RF negative. So in this, 5 or more than 5 joints are involved. Asymmetric or symmetric could be both, small and large joints. They can involve cervical spine, temporomandibular joint. There is a female predominance, and there is 10% chance of uveitis with 40% ANA positive. The other group similar to this is polyarticular GIA with RF positive. So in that case, the difference is the patient will be RF positive or anti-CCP positive. So we call it seropositive spondyloarthropathy. The next group is enthesitis-related GIA. That means there is evidence of enthesitis clinically, and lower limb joint involvements are more common, like hip joints. Axial involvement is there, common in male. SI joints is involved. Then there is anterior uveitis, enthesitis component. These group is the children in these group are actually B27 positive, and they evolve into seronegative spondyloarthropathies, including ankylosing spondylitis. Then the next group is psoriatic GIA, which is in which there is an asymmetric involvement. The small joints are involved, like in adults, dactylitis, onycholysis, nail pitting, uveitis. They are also ANA positive in 60% of the cases and may evolve into psoriatic arthritis. Then the last is systemic GIA. It presents mainly as an arthralgia, which develops into chronic arthritis in 30 to 50% of the cases. The differentiating feature is there is a systemic features like fever, rash, hepatosplenomegaly, lymphadenopathy, serositis, out of which common is pericarditis, pleuritis, and peritonitis. Now, these kind of patients are clinically similar to adults onset Still's disease. There is an elevated level of CRP, ferritin, and platelets. Now, in 2019, the Pediatric Rheumatology International Trial Organization, PRINTO, consensus, they revised the ILR classification because there are certain groups of children who were not fitting into the earlier classification criteria. Like the first one is early onset ANA positive GIA, where the onset is before 6 years of age, and they have ANA and HLA-DR8 positivity. Then the other classifications, they have retained it, but some of them which are presenting with arthritis of more than 6 weeks duration, and but they don't fit any other criteria, they are called as a other GIA. Then if a patient is fitting into more than one criteria, then it can be called as unclassified GIA. The other difference that they have made to the classification is the onset of disease has been changed to before 18 years. Earlier, it was before 16 years. Now, they basically, the PRINTO classification, they have classified mainly into clinical and laboratory criteria. It is almost the same as we have discussed the earlier classification by ILR. The treatment consists of the similar as in adults, like NSAIDs, DMARDs, intra-articular steroids, systemic steroids in systemic GIA. Now, basically, the American College of Rheumatology recommends early use of DMARDs, specifically methotrexate, leflunomide, and sulfasalazine. So, methotrexate, as we know, it is given in seropositive rheumatoid arthritis. It is considered to be the first choice of DMARDs for oligo-articular and psoriatic GIA when NSAID and intra-articular steroids are insufficient. It is also very effective in children with psoriatic GIA, although the axial manifestation limits the role. Now, the next group of drug is leflunomide, which can be used as an alternative to DMARDs for psoriatic GIA. The other is sulfasalazine. So basically, it is given in patients of enthesitis-related arthritis with active peripheral arthritis, but it is not efficient in sacroiliitis, same as with adults. Now, 30 to 50% of the patients where the disease continues to progress, advanced biologics are the next therapeutic step. The first biologic drug registered for the treatment were anti-TNF-alpha agents, etanercept and adalimumab. Etanercept was approved for the treatment in 1999. So basically, they are the most effective drug for the treatment of GIA with influence on pain, stiffness, growth, and quality of life. And they were first successful in the treatment of psoriatic GIA. Then they were subsequently trialed on ERA, enthesitis-related arthritis, psoriatic, and oligoarthritic subtypes. Now, the combination of TNF blocking agent with methotrexate, it increases the opportunity of achieving GIA remission in patients with these subtypes and is an effective option in cases of uveitis-associated GIA. Now, systemic GIA, which is refractory to methotrexate and TNF inhibitors, there are other latest group of drugs which can be used like IL-1 inhibitor, anakinra, canakinumab, and rilonacept. Then there is another one, T-cell inhibitor, abatacept. Then the other one is IL-6 inhibitor, tocilizumab. and the other one is anti-B cell therapy rituximab, which is against CD20 receptors. The latest is oral drug, Janus kinase inhibitor, tofacitinib. Now, apart from the drugs, as Professor Ravi Gupta also pointed out, we need to teach the patient about physiotherapy, occupational therapy, and we need to educate the patient about the progression of disease, about the side effects of all the drugs, about the duration of treatment that is required. Now, in children, usually the surgery is not required, but sometimes in case of chronic synovitis, where there is a synovial proliferation, we can go ahead with synovectomy in order to relieve the pain. Then sometimes if it affects the physeal plate, causing limb-length discrepancy, then we can do epiphysiodesis. And also there is an option of arthrodesis/arthroplasty, which can be done later depending on the age of presentation. Now, spinal decompression or fusion can be done if the cervical spine is involved, like in case of oligoarthritis GIA. Thank you.
Thank you very much, Dr. Mohit, for being brief, and at the same time, you have gone into details about the various nomenclatures and also have talked about the relevant investigation, especially A and A.
Yes,
now,
sir.
all these 4 papers are open for discussion, and Dr. Chinmay Das is there. Dr. Chinmay? Dr. Chinmay? Yeah.
Mohit, one point. Mohit,
Chinmay,
one second, Mohit.
Yes, sir. Yes.
Yes. Doctor.
Mohit, because I joined late, but you have actually all the spectrum of the juvenile GIA you have all told. Very nice.
Yes.
Not able. Some problem with.
Yes, there is some net problem. You can switch off your video, then the audio becomes clear. Chinmay, you are
now
not
it's
able
clear.
Yes,
so I think the voice is coming from the Dr. Chinmay Das's audio. Yeah. Now, I think Dr. Dilip, you can go ahead.
आपस में ही discussion कर ले.
हाँ. So you see, Mohit, they have done very nice thing. GIA you have told. This was my topic earlier. You see, last year I had this topic, GIA.
Right.
So very nicely you have covered up. But one thing I should tell you that if you keep a small 1 or 2, 3 pictures, clinical pictures,
okay,
it would have been more captivating, Clinical picture.
I will keep that in mind, sir. I recently operated one case also. I did synovectomy in an 8-year-old child.
That you should have shown. That you should have shown.
Right. I will. Okay.
Okay. Thank you. Thank you. Thank you, Mohit. Thank you.
Thank you, sir.
I think I've got just one question to Dr. Amarnath and the people, those who are Jha sir also, and also my dear friend Dr. Raja. So whenever treating this ankylosing spondylitis, what is the protocol nowadays you people are following? Dr. Amarnath, what drug is your first line of treatment for treating these ankylosing spondylitis? Because the era we are treating, it has been completely been changed now.
Correct.
Yes.
Thank you, Sonanda. Basically, see now, identification is the biggest thing. Once we identify whether they are HLA-B27 or is it going to be MRI positive. So the radiology will come in later, but obviously HLA-B27 positive or negative RA, the seronegative variety. So that gives us a clue and a play. Third, what is the kind of representation, female, male? Is it in the childbearing age? A lot of things have to be kept in mind in terms of treatment. Because even the first line of DMARD, when we're giving it to a lady, we have to be extra cautious and careful because of the childbearing age. And then in men, it may not make much of a difference initially, but yes, there is an issue with the sperm count and things like that. A lot of people have talked about it, but definitely. To start with the DMARD, and Dr. Jha has also mentioned in many times in many other occasions, where we may have a role of a small steroid initially, but not in a big way for a long time. And sulfasalazine is one of the biggest things. Being a gut-oriented bacterial infection and response that we are going to get in the joints and spine, we need to look at giving them one. Obviously, many of us forget is to give them the probiotics. I have seen that. One, I have experienced it myself, and me being a patient of HLA-B27 positive. I mean, I'm just telling you on the air, but yes, I have seen that. I have made a difference, and it's been fantastic. A lot of patients come back and they say, with probiotics, they have felt very better. That is one thing I would say. Keep that in your drug, armamentarium. Two, obviously, people take and do a lot of shopping these days, even online or maybe physical. So anti-inflammatory stays, but many of them go into the non-prescription. They go to the pharmacy and pick up things. That has to be careful. Anti-inflammatory in a very limited fashion. Exercise is a most important parameter. Simple yoga, school exercise is important for us. Third would be the DMARDs. In the DMARD, we start about maybe if they have any tendinitis and other pain, we can also probably include a hydroxychloroquine to start with 200 or 300. But without tendinitis and other things, it may not make much of a difference. And third, you and I have to correct the osteomalacia. Extremely important. The nutrition. I have seen a lot of deficiencies. Out of 100 patients, 85 to 90 of them are iron deficient. B complex, they are in the pathar, we call it as below 150, below 80, 65, like that they come in. The big 12 should be around 800, 900, if not 900, at least they should be in their 700 something range. Osteomalacia, they come with 5 nanogram, which is crazy. So that has to be corrected. And the response to the medications and the treatment gets much, much better. So that is one thing I have seen.
Okay.
Hope I answered the question.
Regarding this, Dr. Amarnath, I think the audience, they would like to listen by hear from you that what are the characteristics of ankylosing pain, ankylosing spondylitis pain. What is the characteristic? It's definitely different from your low back pain or your any other pain. So,
correct. Compared to mechanical, you're absolutely correct. Compared to mechanical and yes. See now, this particular pain has a resting pain.
Okay.
Early morning stiffness is one of the biggest thing as well. Middle of the night, they sleep and they get turned around, they start to get pain. Now, this pain is there, get up in the morning and they just cannot get on. When once the body gets warmed up, that's when they start to feel a little better. And as the day progresses, they feel better. Unlike in mechanical pain or when there is a loading happening on the spine, there they get pain. This is unlike that. That is one of the typical thing which we talk about, early morning stiffness. And the other thing is, obviously, we have tendinitis. If they're gone into dactylitis, that's another thing we have to keep in mind, the pain and the changes there. Many of them have come with the eye problem. They don't have any other things. They just come with eye presentation. So that's when I didn't realize myself when I had this eye presentation and I neglected it myself. I can vouch for that. When once an ophthalmic check was done, then they said, "Do you have back pain?" I mean, imagine an ophthalmologist talking to me. And I said, "Oh my God." That's when the history changed. This is about 25 years ago. So that's where the whole thing is. And the other characteristic, once you have cervical, or if you have a sacroiliac joint, if you have sacroiliac joint involvement, that is going to be the worst thing.
Yes,
sorry, Chinmay.
I just want to add, you have rightly said that eye pain. So uveitis is one of the commonest symptoms that is with concurrence with your ankylosing spondylitis. And you have also rightly said that there is improvement of symptoms with exercise. That is very good. And regarding this pain, it's I'm just adding, Dr. Amarnath, don't take it otherwise. Yeah. So they have this pain, mainly its onset is before the age of 40, usually, and insidious in nature. Then there is prolonged morning stiffness is there, and there is a drastic improvement with exercises, as our Dr. Gupta has also mentioned that you need yoga therapy and all those severe for improvement in pain. So thank you, sir.
Amarnath, one thing came to my mind that in ankylosing cases, there is also, we have seen cases of tuberculosis of the spine.
Correct.
Tuberculosis
India, yeah, you're right. You're
not rare.
Because,
we have operated also on those cases. So what do you say about those cases? Because there are already there is ankylosing spondylitis, and over and above there is a tuberculosis infection.
See, the Indian tuberculosis, they have given a very clear protocol whether we start them on anti-tubercular drugs. And
early,
we need to...
Very difficult early, 2-3 weeks, 4 weeks time. It is very difficult to diagnose.
True. Dr. Jha, you can add on, sir.
Yes, I wanted to say that as far as tuberculosis is concerned, number one, whenever there is a confusion that it is ankylosing or tuberculosis, suppose you make a mistake and diagnose a case of ankylosing as tuberculosis and you prescribe rest. What happens? Catastrophe. Later on, you come to know it was tuberculosis and the patient has gone so stiff. So always are on the side of ankylosing and not tuberculosis. Number one. Number two, they can coexist only when the treatment has been started, especially in the modern age, with various biologics, without taking into consideration that a prophylactic anti-tubercular treatment is started and then biologics are instituted. So you have to be cautious. Now we will switch over to the second part, and I will be talking there about the various levels of management as Dr. Swarnendu wanted to know. Before that, so the first paper, thank you very much. Yes, Chinmay, yes. Chinmay.
Sir, may I interrupt? Sir, yes. Just I want to add on.
Chinmay, voice is cracking.
The single most important radiological examination is an AP view of the pelvis with bilateral
sacroiliac joint.
I am in the mobile, actually, in the emergency ward. So the single most radiological means X-ray, the minimum what? Yes, with APV of both the sacroiliac joints.
Dr. Chinmay,
with both the sacroiliac joints in a 15-degree caudal view. So
right.
Hello, sir.
Yes. No, your voice was crackling.
Voice so cracking.
Yeah.
So sir, I said.
Now you can hear me, sir.
Little better. Now we will switch over to the second part, and the first paper presentation is by Dr. Pannag Bhushan, who speaks about imaging in ankylosing spondylitis.
Sir, I am unable to share my screen. This is the problem. Okay. So let another speaker speak. By that time, I will just go.
Okay. So now is the turn of Manish. Are you there?
Yes, I am here, sir.
Oh, good.
Manish, good evening.
So Manish has a very fascinating topic, and it says what, when to be given. So you can understand he has outlined various parameters. Manish, please go ahead.
Sir, actually,
Look so magnified. What is it?
Right.
So, well, I think a lot of wonderful discussion has already been on. And so directly switching to the main point, I think everything has been discussed by now regarding the management. But definitely the aim is at this juncture of time when we are discussing to all orthopedic surgeon pan-India that to prevent the joint from the destruction, to prevent the crippling, the aim is definitely to have an early onset of the treatment as early as possible. And after this discussion, I think everybody will be very much clear when to start the treatment. So I'll just directly go to the different modalities. So as we all know, 4 modalities are there, and has been already been discussed: osteoporosis, osteomalacia. All these adjuvant findings will be there with the ankylosing spondylosis patients. Not only ankylosing, all the autoimmune patients, they have all these associated findings, which have to be noted up very importantly. And now coming directly to the DMRDs. So DMRDs are very slow to act. So that one has to remember while prescribing it. It takes week, 1 month, 2 months, 3 months of time, depending upon the drug to be started. And of course, hydroxychloroquine or these preparations are not the right choice. The choices occur gradually from methotrexate to sulfasalazine to the biological drug. So we should start the DMRDs as early as possible, and has been already been emphasized that earlier MRI finding or SI joint sclerosis, these are the things which are very important to be picked up for diagnosing these patients. Definitely, yes, theoretically, it's always better to go for a liver function and RFT test, because at least while going for these or CBC count, you should be able to know what is the basic parameter of the patient, because maybe this patient is already having some renal issues or different problems. So it's always better to have a healthy practice of going for a baseline investigation before starting the particular drug. Now in India, sometimes the cases are diagnosed little late. Now it has not been there in the decades practice which we are seeing. Patients have been diagnosed earlier also, but whenever the patient are being diagnosed delayed, in that case, you need to have a combined therapy, which I'm going to tell very soon. So definitely, yes, again being discussed, pregnancy is a very important thing. Young females, young males have always been there coming to you. So if the patient is a young female, then definitely you have to take a history before starting it. So practically all these DMRDs or the biological therapy, they have to be taken care of, especially while going for a operative intervention. Suppose we are planning for a THR in ankylosing spondylosis patient. If the disease is not a burnt up disease, if it is still an active disease and if the patient is on the biological therapy, definitely you need a stop so that the process should go well. But if it is a case of sulfasalazine, methotrexate, then there is not much need to stop, as it's been very much clear nowadays. So as a monotherapy, yes, methotrexate is a good drug, sulfasalazine is a good drug, but technically both are not good drugs. Why I'm saying both the things controversial here right now is definitely sulfasalazine, according to the different criteria, it is one of the best drugs, although it is a very weak drug as compared to methotrexate. A lot of publication, a lot of papers are there in which even the methotrexate is not been recommended. But again, we'll say in our clinical practice, in my practice also, I've seen wonderful results with methotrexate and sulfasalazine. I'm talking about the axial spondyloarthropathy. Definitely, if it is a peripheral only, then sulfasalazine will work very well. If it is a case of a SI joint, specifically, which we see many times young boys coming, having a SI joint involvement, that is the only clue, no enthesitis, no uveitis, no extra articular involvement, sulfasalazine works well. So on one side, the research or the publication is there, on the one side, the practice is there. Definitely combined therapy has got a role when it is a severe form of arthritis, as already mentioned. So in that case, methotrexate, sulfasalazine, especially if you're dealing with the axial spondyloarthropathy, because these axial spondyloarthropathy, they always sometimes have a shoulder or the hip involvement, although they are axial in nature. So this can be started, and suppose we are lucky enough and the patient settles down, which actually most of the time do, in that case, you can come down step by step. And here, the methotrexate is to be tapered first, then sulfasalazine, actually speaking. No statistically significant benefit is being seen by using methotrexate according to the Cochrane review. However, larger samples, longer period of randomized trial, and in fact, a higher dose of methotrexate has been required because the aim is the radiological progression. So it has been seen at some places the radiological progression does not stop even after methotrexate, but many times, as I've already said, it stops. So all the AS patients are definitely not going to get benefit from non-biological therapy. In that case, we need to go for a biological therapy. Now, the biological therapy means, I think we have discussed by now, anti-TNF, especially infliximab, is supposed to be a wonderful drug for axial as well as peripheral spondyloarthropathy. Then secondly, in 2015, introduced IL-171 therapy, cifralimab, and now a JAK inhibitors are there, wonderful drugs. So with the coming of the JAK inhibitors, anti-TNF may be a pass. Actually, the radiological progression should be stopped. Although the Cochrane review says many times that radiological progression do not stop with methotrexate and sulfasalazine, but as I've already mentioned, it is not a very important thing. It needs a topic to be discussed and to be presented and to be worked up more actually. Now, almost complete resolution of spinal inflammation is seen in many of the patients, which is being published across the globe by giving infliximab, because the documentation is very important. And here is a well old 1.5 decade back case of spinal inflammation, which has been published, in which it will be proved that the baseline, there is a lot of spinal inflammation. And here we can see in the after 24 weeks of infliximab, that complete resolution of inflammation by MRI was being there. The issue with TNF-alpha is cost, no doubt, immunogenicity, induction of lymphoproliferative disorders. That is why everybody, we don't want to start. And definitely, yes, tuberculosis. Induction of other autoimmune disease. A person having AS may gradually develop maybe a diabetes also, or other thing, even a tuberculosis gradually, if it's not autoimmune. And lastly, but not the least, is not everyone improve with the infliximab. Then why to go for it? Just go for a sulfasalazine methotrexate. So though there is a prescribed dose schedule for the infliximab, but it is very costly, and even in the Western countries, people get bankrupt about this. And it has been seen in the publication that even a low modified dose works well. So that is so much powerful infliximab is. And here is a busy chart of all these biologicals, in which definitely we can appreciate that infliximab, JAK inhibitors are wonderfully well, but IL-1 inhibitors, this T-cell inhibitor, they don't work very much in these cases. Until today, even in the peripheral disease, sulfasalazine has been told by the EULAR also is the wonderful drug and it works very well. And for the axial disease, if you say to establish drug, it is a TNF-alpha blocker. But otherwise, as I'm saying, it works very well with methotrexate and a sulfasalazine combination both. And definitely you need to work out whether your patient is having a bad prognostic signs or not. And that bad prognostic signs means that that patient should be not having any uveitis, extraarticular symptoms, maybe not having any mixed psoriatic picture, maybe not having any cut involved. In that case, that is a dictum that patient is having a bad prognostic feature. And here you have to take it very carefully well whether these TNF inhibitors or biological therapies should be started or not. Well, infliximab wonderfully not only take care of the spinal portion, but definitely the gut inflammation, bowel disease, and as been discussed just now also, that yes, probiotics has got a wonderful role, which is a very good add-on thing. And definitely, yes, if these patients are having a psoriatic associated with uveitis, then don't go for methotrexate sulfasalazine. But usually, I'll say, we don't get so much complicated cases. Again, the same thing is algorithm. Finally, any COX inhibitor, the short steroid, and then TNF inhibitor if you are dealing with an axial spondyloarthropathy. In which infliximab or etanercept, infliximab is a costly, and the cycle of 0 to 6 weeks is recommended, but as I've already mentioned, many times even a lesser thing works very well. But again, that is not in publication. Now, in the peripheral arthritis, definitely go for a sulfasalazine, no doubt about that, unless and until it is having a bad prognostic feature. So in that case, you have to switch over to anti-TNF and then gradually back to sulfasalazine when things settle down. And now with the target synthetic DMRDs available, so tofacitinib is taking care of everything, but the time will tell whether we are going to go for it, not from the pharma company industries, but definitely with our clinical experience, or whether it's still sulfasalazine and methotrexate will be the gold standard, rather sulfasalazine, I would love to say. Biologically, improve the treatment of spondyloarthropathy by slowing the progression of joint destruction in the way which is possible. And no doubt, I think all these therapies will have a long way in coming decades or years of time in teaching us which is the better one. And definitely, yes, with the mesenchymal stem cell regenerative science into play, lot of thing has been there, which, like as I've already mentioned many times, that the RA biological therapy MSCs works very well. So it works very well again with the ankylosing spondylosis, but again, it's MSC is not in our protocol from BCGI or ICMR and the guidelines to say that it should be used. Thank you so much for a very patient. Thanks a lot.
Yes, am I audible there?
Yes, sir.
Okay, I am audible, but something has happened to my screen because I was trying to locate your presentation in my screen. Okay, so
anyway,
Dr. Pannag, you are there?
Yes, sir.
You go ahead with your presentation. At least
Right,
I am
sir.
audible.
Right, sir.
Yeah, good evening, Pannag Sahab.
Namaskar, sir.
A long time. Namaskar, namaskar.
Right, sir. My screen is visible?
Yes.
Yeah.
So, much has been said. I do not have to say many things except the imaging, and I will stick to my presentation. This is bamboo spine, the commonest thing taught for the last 30, 40, 50 years. And the bamboo spine,
Sharing.
Yes, sir. And this bamboo spine is just like the old bamboos, which used to be there in the villages, the real thick bamboos, not the thin bamboos, with the nodes and internodes.
Pannag, your screen is not seen.
No, it will be just a minute.
Now the shiny corner sign.
No, your screen.
Your screen is not visible.
The screen is not visible.
You have to share your screen, sir.
No, you do one thing. You stop sharing and then go to share. Don't go to PPT. That is the idea. Go to stop share, go to share screen, and then after that you go to PPT. Don't go to PPT first.
Right. You have to minimize the PPT.
Correct.
Is it okay?
No, not yet. Stop sharing totally. Yeah, now you're coming on. Now we can see the screen, but you have to come on to your PowerPoint presentation. This is from your mobile.
Yes, I'm from my mobile.
Yeah.
I could not do it from. Can I go to another part? My presentation?
It is still buffering. There's a phone call coming from somebody.
Actually, this.
Is it okay now?
You're sharing screen. Now you have to share the screen.
I'm sharing screen.
You have to share the device. Audio on is there, and then you have to
Audio on.
Yeah, audio on, but you have to start to share your presentation now.
Right, sir.
Go to your presentation now.
Is it okay?
Now, shiny corner will come. Shiny corner
sign.
Yes. So I will come with a bamboo spine. Am I visible, sir?
Very good quality.
Yes.
Very good quality X-rays Thank you.
Sir, so this is bamboo spine. It is just like the old bamboo. I have already talked about it. Then comes the shiny corner side. Actually, what happens, as we had been talking about the pathology, the corners where the anterior longitudinal ligament and the annulus fibrosis is attached, due to enthesopathy also, there is some lesion, lytic lesion at the corner. And this corner, in response to it, when bony deposition occurs at the corners, it is just like a shiny corner sign. A squared vertebra with a shiny corner sign. Now, so if we go to the vertebral radiology, we can see the fused facets. We can see the fused facets.
Yes.
We can see the squaring of the vertebra. Actually, the anterior body of the vertebra is concave, and the anterior longitudinal ligament, the shortest ligaments, they get ossified first. So there is anterior straight margin, which leads to a squaring of the vertebra. Now comes the syndesmophyte. There is a difference between syndesmophyte and osteophyte. Osteophyte is the ossification of anterior longitudinal ligament, whereas the syndesmophyte is the ossification of annulus fibrosis. And the posterior longitudinal ligament ossification is also there. Then comes a dagger sign. Dagger sign, when the facets are spared and interspinous and supraspinous ligaments are ossified. It is just like an old dagger which the knights used to play. All these signs are the signs of vertebrae with excessive ossification. Many a times, the interspinous and supraspinous ligaments are spared in type of ankylosing spondylitis, but the facets and the capsule of the facets are involved. It is a trolley track sign or the tram track sign. It is just like the railway line or the lines on the roads of Kolkata. Then comes the Romanos sign, sir. Romanos sign is more visible on MRI. As you can see it beautifully, these signs represent early findings in inflammatory spondyloarthropathies, such as ankylosing spondylitis, we all know, enteropathic arthritis, and appears as irregularity and erosion involving the anterior and posterior edges of the vertebral end plate. So it is not on the anterior end plate only, it is seen in the posterior end plate also. Syndesmophyte and osteophyte, as I have already told you. So, sir, as you can see, in AP view, the ossification occurs in annulus as well as the longitudinal ligaments. And many a times, there are spurs. These spurs are known as traction spurs. This is the filling of the bone in an acute angle between the anterior longitudinal ligament and the body. Same with the lateral approach also. In this, there can be a paravertebral ossification. There can be claw osteophyte, as you can see. There are traction spurs, and if it is continuous, it is termed as undulating anterior ossification. So undulating anterior ossification or the traction spur or the claw osteophyte or the paravertebral calcification or ossification, if these things are present, a suspicion of spondyloarthropathy should be there, and it can be ankylosing, psoriasis, or enteropathic, all the three. The hip joint is a major joint involved in spondyloarthropathies. And the best part is that this arthropathy, as you can see, the osteophytes are more on the femoral aspect, not on the scapular aspect. And many of the workers, especially when I was going through the Resnick and Nivayama in my PG days, they have especially mentioned that if you see a hip osteoarthritis and you can see osteophytes along the line, most likely you are dealing with ankylosing spondylitis and go and try to examine it. Then, as told by others, there is enthesopathy. Enthesopathy is something which is seen wherever the ligament is attached and where there is chronic inflammation. The hatchet sign, typical hatchet sign of the shoulder, the anterior border of the hatchet is just same as the attachment of the supraspinatus over the humerus. Sacroiliac joint, here the disease starts. Am I audible?
Yes.
Sacroiliac joint, where the disease starts, initially there is a fuzzy sign, then there is a widening of the ligament due to sacroiliitis and the effusion, then there is marginal sclerosis, and then the joint starts getting filled up with the bone, and finally it is fused. It is the last stage, stage 4 of sacroiliac joint. Then comes the Anderson sign, as Dr. Amarnath was talking. Many a times for diagnosis, we should go to the MRI. They say spondylodiscitis, that is destructive lesion at the central, not at the anterior posterior. Anterior posterior is Romanus sign. But if it is in the center, as you can see, it is known as Anderson sign. Actually, it was in 1937 at Stockholm, the Anderson came out with it. Usually due to stress fractures or the local delay in having presentation being the last mobile lesion. Better seen in MRI. Then comes the dish. Dr. Jha has beautifully talked about it. It is one thing which is the ultimate of osteoarthritis of the spine. I do not want to add anything on Dr. Jha's knowledge, which is almost impossible. MRI and PET-CT. Here we have come to the spondyloarthropathies and ankylosing spondylitis. MRI, I have already talked, and PET-CT is something which I will talk later. As already told and talked by others, whenever there is spondyloarthropathy, we should not forget stenosis, we should not forget hyperparathyroidism, we should not forget psoriasis, atrophic arthritis, and other diseases as mentioned by our previous speakers. But psoriatic arthritis, we must look at the middle joint and the distal joint. That is DIP joint and the PIP joint. Then the AP view is more informative about psoriatic arthritis because the lateral ossification of the spine occurs more other than the anteroposterior, as you can see here. Then enteropathic is slightly different. The enteropathic arthritis of sacroiliac joint has a different pattern, as you can see, with more of density and adjacent osteoporosis. And this is the last slide about the PET-CT, last but one. Here is, as you can see, there is more of bone formation than the bone inflammation. Here is a game changer. When people thinking that it is more of bone inflammation and we give infliximab and all those things, IL-17, IL-22 inhibitors. But here, as we can see, there is good amount of bone formation also by the fluoride tagged glucose uptake in the PET-CT. And technetium bone scan, this is something which is almost outdated. We did not talk about it. Thank you, sir.
Thank you. Thank you, Dr. Pannag, for
very nice. Yeah.
doing real justice to the radiological investigation. You have talked about all the basic signs that should be seen in a radiograph. Now,
you have to stop sharing, Pannag.
Yes, Pannag.
Right.
Now,
but Pannag has shown excellent photograph.
Yes, we will have discussion in the end. So now the next speaker is a spinal surgeon from Madurai, Dr. A. Razamani. So he will speak on cytokine inhibitors, and since he's a spinal surgeon, he will also very briefly touch the topic of spinal surgical interventions.
Rajamani,
Yeah. Hi, Dilip.
Yeah. How are you? Fine.
Very fine, very fine, very fine. Good evening to you.
Wonderful.
Are you seeing the screen?
No, you are visible. Your screen is not visible.
Shared it?
No, no.
Now?
No. Rajamani, what I was telling Pannag, you now you're okay. Okay.
Good.
You have to go to the PowerPoint presentation, full screen.
Okay?
Yeah.
Yes, good evening to you all. So a lot of things are being told about the various drugs that meant to give. And whatever it is, our understanding is neither medical nor surgical is going to cure the disease. But our aim is to reduce pain and slow down the joint breakdown. And the goal is ultimately control the disease and to prevent further damage and deformities. Medical treatment is only to modify the disease. As you all know, it's a DMRDs, the name itself is indicate. But no single drug is guaranteed and the patient reacts to drugs differently. And the drugs of late introduced, as you all know, fight against certain immune cells and reduce immune mediators or block immune cell functions. And patient may be treated with one or combination of drugs which have been very well described earlier by the speakers. And now, first line of DMRDs include methotrexate, leflunomide, and all these sulfasalazine, etc. When the first line of drugs don't work, second line, that is the biologics, are coming to play. And whenever you choose a biologic, choose a less potent drug first because medically suppressing, it can produce, aggravate, or induce infections in the GIT or tuberculosis. The treatment has to be individualized because the response vary from one to another as mainly depend on the gut microbiome. For example, certain bacteria help to convert the dietary fibers into short chain regulatory cells to suppress the immunotherapy response. Whereas certain bacteria hinder drug absorption. For example, certain bacteria metabolize the methotrexate so quickly that the body cannot absorb the drug. Now coming to the cytokines, cyto means cells and kinos mean movements. It is nothing but a low molecular weight protein, a glycoprotein. The crucial role, they have a crucial role in regulation in various aspects of the immune system, both intensity and duration, and mainly important role in the inflammatory response and also hematopoiesis. They act by cell-to-cell communication, the coordinated muscle response versus antigen, and they got a significant role both in innate and adaptive immune response. The cytokine binds with specific receptors and it triggers a cascade of reactions, leads to proliferation and activation and differentiation of various varieties of immune cells to coordinate when they to eliminate the antigen that is involved in the disease. There are 4 types of modality of action for the cytokine inhibitors. Either the synthesis of the cells, cytokines is the use, or the concentration in the active form is decreased, or there is a block their interaction with the specific receptors, or finally interfere with the signaling of cytokine receptors in the cells. To say an example, the reduction in the cytokine synthesis by reducing the cytokine cells, that is cytolysis, mainly done by methotrexate, and it is mainly by the complement lysis. Quite surprisingly, when we use steroids for glucocorticoids for a longer time, even before it has got immunosuppressive effects as an anti-inflammatory drug, it inhibits the interleukin-1 and T1 necrosis factor. It inhibits the cytokine gene expression. In that way, it can act as a cytokine inhibitors. Next drug which decrease the free active form of cytokine or the monoclonal antibody commonly used nowadays of about the influenza, which was told earlier. And this is mainly works by antigen blocking the antigen binding parts. It's an IgG molecule. There are other soluble receptors which act on the non-antigen binding parts of the IgG molecule as a receptor for tumorous necrosis factor. And finally, the target inhibiting the cytosine receptor itself, basilizumab and daxlimab, which suppress the mainly interleukin 2 receptors and suppress the cellular immune reactions. Anakinra and all comes in this category. And then finally, it acts within the cell. The cytosine inhibitors inhibiting the genetic modulations. They block the receptors. There are sirolimus which are on trial, which probably will come into the existence in the due course of time. Now, coming to the second part of my talk, that is the spinal surgical intervention. The spinal surgical intervention comes to address all these problems. When there is an instability which produces pain, not the pain like any other disease process. When there is an instability, produce pain, it has to be addressed, and a deformity. And when there is a neurological compromise, this has to be addressed by surgically only, by way of osteotomies or decompression or instrumentation and fusion. Now, before doing surgery, every surgeon has to have a caution about it, because over a period of time, these types of diseases, the patient will take a lot of steroids. And as a surgeon's point of view, you have to think about an osteoporosis in these cases, which mainly intervene, you have to modify your stabilizations, and probably it will give you delayed fusions in your surgery. And once again, the wound may take a longer time to heal, which leads to infection. And there are other joints involved, hip and knee, which delay the rehabilitation process. So a surgical intervention needs a prerequisite is the preparation of the patient, mainly the cardiorespiratory reserve has to be built up by way of respiratory exercise as a preliminary. And the drugs, steroids and biologics, a lot of things have been talked earlier. It's necessary to stop the drugs, certain drugs, which drugs to be stopped, and when to restart the drugs following surgery, and the role of fusion when the drugs are on. And as I told you earlier, you have to keep it in mind the wound infection. Now, major problem is positioning the patient is always a major concern in these types of surgeries. And you see this, and always when the neck is also stiff, it gives a lot of problems for intubation. You need a lot of special gadgets to do that. And while doing surgery, especially in dorsal and lumbar and cervical, you need to have a neuromonitors. Without that, better not to operate. With all these things, you have got a high risk for the patient. That is why majority of the times people don't take up for surgery. But these are all the things to be addressed. They mandatorily has to go in for surgery. Unfortunately, you see the position of the patient is almost neck is like this and the body is like this. This is the amount of deformity in these cases we deal with. But fortunately, I'm not the opportunity to operate on this patient. This is the position occupied for the eye surgery. This is just to show how difficult sometimes to keep it in the positioning. Next, coming to the various types of surgeries, that is mainly the deformity. When the deformity is there, cardiorespiratory research is going to be worse and worse unless we correct the deformity and follow with physiotherapy, it cannot be improved. And then when the patient can always look down and the posture becomes a very bad, it occupies a lot of disturbance associated problem. And it can be corrected by various osteotomies, pedicle subtraction, and split-person osteotomies with an instrumentation. We do correct all these things. Now, when the deformity is in the lower back, a flat back, the whole body sagittal balance is altered, and it itself can produce a mechanical pain, and it can be corrected. Now we have got a lot of instrumentation, screws, and then the intervertebral discs are available. We correct and then achieve a fusion. Apart from the spine, hip and knee is also involved, which has got a very big role in rehabilitating the patient in total. And so we have to correct stage by stages according to the priority of the patient. But one thing we have to inform the patient is a progressive disease and repeated surgeries may be necessary for these patients. And then fracture, coming to the fracture, it produces a fracture. The whole entire vertebral column moves in one segment, and so it is likely to get displaced easily and it can produce a neurological deficit. These are all the things to be stabilized by various techniques, and you have to get it right to have a good neurological recovery. And sometimes injury need not produce neurological compromise, especially in upper cervical spine, where you get the inflammatory tissue itself can produce a cord compression, or it can produce an atlantoaxial dislocation and can produce a neurological deficit. Now we have got options, varieties of options. In those days, we used to do wiring. Now we have a lateral mass and pedicle screws are available, and then we do a scientifically biomechanical understanding with the good biomechanics of the instrumentology. We do a lot of comforts for this patient in the upper cervical spine also. So to conclude, surgery or medicine cannot cure the disease. We aim at reducing the pain and slow down the joint breakdown, control the disease and prevent further damage and disease. It is a lifelong issue with the vaccine and banning. Our aim is to make functionally the patient comfortable. And treatment has to be individualized with a combination of any of these lists, NSAID, DMR, biological, cytotoxic inhibitors. And then, as I told you earlier, these are all the things to be addressed surgically: pain due to instability, deformity, and then the neurology. And then technical difficulties, as I told you, intubation difficulty, positioning, and surgical risk of neurology. We need to have an expertise, and then you need to have a monitors, neuro monitors, where you do perform surgery on this patient. Results, of course, vary with the individual profile, the disease status, and other modalities. Surgery has got a definitive role when you have to address all these problems of pain, deformity, and neurology by way of osteotomies, decompressions, and fusion. And repeated surgeries may be necessary because the progressive disease affects the spine as well as hip and knee. Thank you for a good opportunity. Thank you, Jas sir, and then the IOA for giving me this opportunity.
Thank you, Dr. Rajamani. You have done a great fusion between the two aspects of management of ankylosing spondylitis. So thank you very much. Now is the time for last presentation. Just give me a minute. So friends, as I was asked a question from Dr. Swarnendu that what should be the real line of management of Spondylou Arthropathy. Right. So we have formulated guideline for management, and it cannot be just haphazard, and it is not your choice that you start one drug and then again switch over to another without any reasoning. So first guideline, who you should be able to suspect a spondyloarthropathy. So the various painful aspects have been discussed, but patients with 3 months or more of chronic inflammatory back pain and age of onset is less than 45 years. You requisition a specialized investigation, obtain MRI of the sacroiliac joint, which will detect active inflammation in the sacroiliac joint, and also HLA-B27. So patient with more than 3 months chronic back pain under the age of 45. Guideline number 2. Now suppose the diagnosis is there. So you have to ascertain and classify whether it is a axial spondyloarthropathy or a peripheral spondyloarthropathy. Purposely, we are not mentioning about psoriatic arthropathy, but invariably, most of the psoriatic arthropathy have major peripheral element. Now, guideline number 3 is, once the disease has been diagnosed, you have to say it is active axial disease or it is stable axial disease. Now, when do you say active axial disease? when the symptoms are at an unacceptably bothersome level. And number two, it must be an inflammatory back pain as judged by the clinician. What are the stable ankylosing spondylitis features? The disease is somewhat asymptomatic, or symptoms are there but at an acceptable low level. Clinically stable, it becomes in 6 months minimum following treatment. So the time that the patient inquires, you should say it will take minimum 6 months to stabilize. Now comes the therapy. So first line of therapy is NSAID. Continuous 2 NSAID. Friends, let us remember, in rheumatoid arthritis, NSAIDs are not recommended. It is only in ankylosing spondylitis or spondyloarthropathy that NSAID still has a role. So 2 NSAIDs, not at the same time. Each one and the other one 3 weeks, or 2 weeks the first one and 2 weeks the second one. There are no preferences, but an individual orthopedic surgeon, and for that matter, a physician, may have his own preferences. No systemic glucocorticoid is to be given. I think Dr. Amarnath was speaking about it, that glucocorticoids are not the drug of choice in spondyloarthropathy. Peripheral arthritis, if it is there, you prefer sulfasalazine over methotrexate. Now comes in the first line of therapy, apart from NSAID, if at all you have to use glucocorticoid, you can use a local infiltration of glucocorticoid if 2 or less than 2 peripheral joints are involved. You can also infiltrate into the isolated inflamed sacroiliac joint, but you must definitely avoid enthesitis areas, Achilles, patellar tendon, and quadriceps for fear of getting a rupture. Physiotherapy is a must. So this forms the first line of therapy. Now, second line of therapy, in cases of active ankylosing spondylitis, despite NSAIDs, the patient still is not becoming asymptomatic. So the first choice is TNF-alpha. There are no preferential one. So have your own TNF-alpha. Like, for example, I personally prefer etanercept over infliximab. I have a publication in which I have shown that only half the dose, 25 milligram weekly in Indian patients, is highly effective. Second choice, if they have not worked, then secukinumab or ixazumab, and the third choice is the oral tofacitinib. Mind you, this is only the third choice. Don't convert it into first choice. And if a patient has ankylosing spondylitis with inflammatory bowel disease or uveitis, prefer monoclonal antibodies like infliximab, adalimumab, certolizumab, golimumab over other biologics. So this was second line therapy, the biologics and tofacitinib. And guideline number 6 says, still your patient is not improving, hold yourself, stop, and again look into the disease parameters. So no relief on biologic. Now is the time further investigate and perform again a spinal or pelvis MRI. Now, still the patient is an active disease and is not responding. So here we start the third line of therapy. That means first degree non-responder despite TNF-alpha, the first strong choice is secukinumab or ixazumab. And then here second choice becomes tofacitinib. Now here can be economic reasons to switch over to tofacitinib, which has become cheaper in India than compared to the first one. The second degree non-responder despite TNF-alpha inhibitor, any other alternative TNF-alpha inhibitor can be prescribed. So as far as the medicines were concerned, they are all over in third line of therapy. Now coming to a stable condition where the patient has responded, physical therapy, and what kind? Don't send a patient to physiotherapist. Unsupervised back exercises. Let there be a formal group or individual self-management education. A stable ankylosing spondylitis on biologic. Please do not discontinue or taper. Otherwise, there will be a relapse or flare. NSAIDs can be given SOS on demand. Stable on TNF-alpha and NSAID, stop the NSAID. Stable on TNF-alpha plus oral targeted synthetic DMRD, that is tofacitinib, and continue TNF-alpha alone, stop TS-DMARD if the disease has become stable. General management at all stages, this is guideline number 9. Monitor using validated ankylosing spondylitis disease activity scores. So DAS CRP or DAS ESR should be performed regularly. Avoid using treat to target strategy with target of AS DAS less than 1.3, which is remission, or low disease activity 2.1. So it is better that you look for strategy-based management. But treat to target also is one of the modalities in rheumatology for treating the patients. Avoid, very important, avoid repeated spine radiographs at a scheduled interval. Avoid obtaining spinal or pelvic MRI to confirm inactivity unnecessarily. Well, as has already been told, if there is advanced hip arthritis, total joint replacement, kyphosis in a specialized center, perform spinal osteotomy, and if there is spinal fusion or there is advanced osteoporosis, which always is there, which is hidden, first of all, treat osteoporosis and then go for spinal instrumentation. Well, guideline number 11 is meant for our country where we start using traditional DMARD. It is recommended using traditional DMARDs de novo in higher dose or following biological therapy whenever cost is a constraint. Sulfasalazine is a preferred drug. Even otherwise, this is potent anti-inflammatory, has antibacterial and immunomodulator role. Well, in psoriatic arthritis, higher doses of methotrexate are more effective and results are comparable to rheumatoid arthritis. So remission is achievable in 20% of psoriatic arthritis. Thank you very much. Now, since we do not have much time, we can have 5 minutes of discussion. I think Dr. Swarnendu, this whole presentation answers your question that what are the stages in which a patient should be treated. Dr. Dilip.
So it is always
actually we have
covered. It is always a pleasure, and it is always we are lucky to listen from the master like you. And I think this should be the guideline should be followed throughout the all over who are following the IOA. It is an excellent, extraordinary lecture whenever we see and listen to you.
Right. Doctor, thank you. Dr. Dilip, you wanted to...
Dr. Jay, you can stop sharing, sir.
Yes, yes.
Yeah. Stop sharing.
Dr. Amarnath, please.
No, stop sharing. I said that's all. I requested you.
I forget.
And then Dr. Dilip, you were asked about the tuberculosis. In my slide, for some reason, it had not shown. I skipped off. One, obviously, Monto test, obviously. Another one is, TB Ferron Gold or Gold Plus is a must to see whether we have an active tuberculosis or not. So I just wanted to update that.
So, Amarnath, I understood it, and thank you very much that
another one question to Chaddha and all this.
Bangalore also, you have invited me, Bangalore.
Yeah.
Sir, I will,
St. John's.
Another one question to Chaddha and all the senior degrees.
Hello.
Dr. Swarnendu is saying something. Yes.
Yes. Bhushan sir. No, I think Bhushan sir is saying something. Bhushan sir, you continue, then I will take.
Sir, long back, I had a talk with a senior scientist of Genome Institute of Singapore, and maybe 2 years back, and he insisted that I should give probiotics. I started it, I'm happy. Actual protocol is that you should culture the gut flora and find what is deficient. Sir, I request Jha sir that in his protocol, he may add probiotics wherever he feels fit after a wee bit of thinking.
No, you're right. It will be a general recommendation, common recommendation for use in whatever stage.
Yeah.
Right.
Yes, sir. And in developed countries, they take the gut flora, culture it, find out which is the flora which is deficient, and they give that particular flora. But anyway, we have plethora of the probiotics we can give it, and it happens.
No, in fact, Bhushan, I agree with you, because a lot of my patients have not gone on to the biologicals after, they have been under remission for a long time with probiotics. That is one thing which is very good.
Another question to Jha sir. Sir, there is another one, when we read ankylosing spondylitis and the association of other medical issues, like diabetes is also very common with your ankylosing. So what's your take on this?
These diseases are common, as I have said, before the age of 45. And it is only the late age patients who have diabetes. So like any other disease, this could be an accompanying disease, and you have to treat. And as we have already discussed, steroid is not to be given in these patients. There is an undercurrent of osteoporosis, which because of diabetes also is more prevalent. So osteoporosis will have to be treated. And definitely, whenever you are going for some kind of surgery, this aspect will also have to be looked into.
Another one question to Amarnath sir, that when you use these probiotics, what's your dose, what is your drug, and how long you continue? Continue for lifetime, or what is the protocol? Because I have never used that.
Thank you, Swarnendu, because this is one thing which I have noted, and probiotics, as Dr. Pannag was talking about, there are a plethora of them, whatever suits the patient best. And the fecal, now we have the fecal tablets available. Yes. Fecal tablets, when I say, don't get me wrong, in that sense, it's been very well cultured, and not just simple probiotics of lactobacillus. No, the fecal bacterial cultures have been taken and specifically available. There are plethora. I will talk to you about that. There are different brands. We can talk about that. So that I have seen, because with an IBS and a Crohn's laying down inside without being diagnosed or probably coexisting, unnoted, people have come back. I have given etanercept for 2 years, and cost was a factor. And then the insurance segment has opened up in a big way. Last time I mentioned about it. So there are a lot of things which I'm also covering. And I'm in the insurance segment for 15 years. Just pre-COVID, I stopped. Now, with that, even a simple change in the shift of probiotics made a massive difference And I was really surprised. And that's when there was no protocol anywhere to give. So that's where I said, let me start that. That's the reason I told in the talk as well, many of us are not using it. So that has to be given. And when I spoke to the gastroenterologist, they said, yeah, it should be okay as long as it doesn't make much difference, you use it. I said, chalo, then we karenge. There are more than 15, 20 patients of mine who are absolutely, not on any biologics now for last 7 to 8 years now. They've just been taking one occasion paracetamol or nimesulide. They are very happy with nimesulide. Some companies are manufacturing it. And this is one thing I've seen very, very effective. I don't know why and how, but they're happy because they're not spending a huge amount of money on the biologic now.
Right. So now we will have to close. Otherwise, very interesting discussion was going on.
Yeah,
I will request Dr. Dilip to propose.
Yeah, thank you, Dr. Jha, because there is we are going late into the midnight. So I will just be brief about, because I came late. Yeah,
and you have to thank also. You have to thank
I will give the thanks also, because Ravi has started. I actually cut up the line from Ravi, who has got the HLV 27. He has covered the interleukin pathways and etc. is an excellent coverage. Amarnath, excellent. Amarnath investigation without this radiology, investigation, he has done a very good insight about the ANA. But I was really surprised to see that the irritable bowel syndrome, along with that, rheumatoid, Spondylou Arthropathy cases. So how you will be dealing that, actually, I'm still not clear. Mohit Arora has got the juvenile idiopathic at the GIA and all ANA tests he has recommended. And Manish, wonderful with what, when, how, why, and all these things. And Dr. Jha has done a double presentation and elaborately 11 points. We'll never forget that Dr. Jha has told us how to approach for this Spondylou Arthritis cases. Actually, Rajamani, very nice. Rajamani have shown that actually reminded of me of my earlier days when he used to do the spinal C1 skull to C2 fusion, not with the plate, but with the wire, the external table of the skull. That actually reminded me. And do you remember Rajamani in Bangalore? Hello? Rajamani is left, I think.
No, he is there.
Remember very well, very well.
He's there.
Rajamani, you have enjoyed there in St. John's.
Yeah.
Do you remember?
I remember very well.
Yeah. So Rajamani, you have actually ignited my this memory long ago, 30 years ago, that used to fuse this C1, C2. Skull to C2. We have shown a plate there. So that actually reminded me. Thank you very much.
And Dr. Manish is there or he has left?
Manish has left.
Okay.
Manish has left, but Manish has ignited the fire. He has what, when, how, and why. Manish is a very eloquent speaker and he touches the hearts of many. So thank you, thank you all of the golden speaker. To see you again next time. Beautifully have covered up many things. Mohit, everybody has done an excellent job of combining everything, and I will not forget the 11 points to take home for a lifetime treasure. Thank you, Professor Jha. Thank you, Professor Jha. Thank you, Professor Jha.
And you have to close also?
But, yeah, I was actually thinking of our this Tiwari, but he is could not attend, I think, because of his
he has not attended for certain reasons.
Yes, please.
And very nice to see. I thought that that Pannag has left because he has left a message here. Yeah.
No.
So thank you. Thank you. Thank you to see you again. You are very energetic and you have got
our convener wants
very
to
wide
say
smile. And where is our convener? I don't know.
Thank you, everybody.
Where is our convener?
Dr. Pannag, you will say something, last few words.
Yeah, few words. Sure.
I'm very happy with this, and I will sum up in one line of Hindi. कि अगर देखना चाहते हो इंडियन ऑर्थोपेडिक रूमेटोलॉजी की उड़ान को, तो कुछ और ऊंचा करो अपने आसमान को.
Very good.
अरे वाह.
Okay. So,
good day to all. Good night.
Dr. Swarnendu, thank you very much for joining as panelist. Wish you all the best. And thank you all the speakers. All of you were so wonderful. Thank you, Dr. Amarnath.
Thank you, sir.
Your presentation, you have really labored hard.
And Amarnath has done a very nice thing. Amarnath, sorry that I could not take your invitation in Bangalore.
You should next time. Definitely.
Next time.
Yeah. We'll make it happen.
Thank you.
Dr. Rajamani, thank you. Very good.
Rajamani will see you in Madurai. Thank you.
Thank you.
Right.
Thank you, everyone, sir, and good night, sir.
Yes.
Thank you, everybody. Thank you. Good night.
Thank you,
good
sir.
night.
Good night.
You are still there, Chinmay. Very highly thankful. Right.
Thank you, sir. Thank you, sir.
Alok was there. Alok, are you here? Alok had joined, but he has left.
I think Alok could not join. I think Alok is not there.
Join. Okay.
Alok means who Alok? From
Alok Agrawal.
See Dilip after some time somewhere.
Yes.
Pardon?
He wants to meet you somewhere.
Yeah, Dilip.
Dr. Rajamani wants Dr. Dilip to meet him somewhere.
Rajamani, I will be coming to Madurai soon.
Yeah. Welcome. Always welcome.
And Mr. President, thank you very much for remaining throughout the meeting. Dr. Lahkar. Right. So, any new information you want to give?
No, where is our president? Is he here?
Is there? Yes. He has been present throughout.